It is just a huge honor for me today to be podcast interviewing Donald L. Chi, a board-certified pediatric dentist and health service researcher, is a professor of oral health sciences in the University of Washington School of Dentistry. He is also a professor in the School of Public Health and serves as an associate chair for research in the Department of Health Services. He has adjunct faculty appointments in the Department of Pediatrics School of Medicine and Department of Pediatrics Dentistry School of Dentistry. His research program focuses on children's oral health inequalities. He is interested in adapting knowledge from the social and behavioral science with the goal of eliminating inequalities and improving oral health for vulnerable populations. In 2017, he received the International Association for Dental Research Distinguished Scientist Young Investigator Award and was named Pediatric Dentist of the Year in 2018 by the American Academy of Pediatric Dentistry. Wow, and then some wow. I mean, that's amazing. Dr. Chi has published over 100 peer-reviewed journal articles. He is chair of the American Academy of Pediatric Dentistry's Council on Scientific Affairs and serves on the editorial boards of the Journal of Dentistry for Children and Biomed Central Oral Health. He teaches public health and clinical pediatric dentistry to dental students and residents and continues to treat patients at the Odessa Brown Children's Clinic in Seattle's historic Central District. Before we get into everything you've done, which is just beyond amazing, you are you're a DDS, you have a PhD, you're a double doctor, and you are in Seattle, Washington right now. The markets are plummeting. I can't remember the last time the stock market ticker has been tripped because the short orders were past 5%. But with your epidemiological brilliant mind in the epicenter of the outbreak in Seattle, Washington, is this media hype, or is this going to be like our regular flu season and 20 to 80,000 elderly Americans die of the flu, or has this got you worried?
I'm worried. I actually, my family and I had a trip planned to Korea. We were actually supposed to leave about a week ago, and coronavirus, as you know, has been going on in Korea for the last few months. And we were in touch with family and friends to try to figure out if it was safe to travel. So I feel like I've gotten a little bit of kind of on the grounds information from family and friends in Korea. But here, I am worried. I think there's so much we don't know about in regards to the coronavirus, how it's even spread, who the vectors are. And so I think that what we're doing here in Washington and here at the UW School of Dentistry, I think is really safe, preventive measures to make sure we're not contributing to the spread of coronavirus unnecessarily.
But on the one hand, China and Italy are closing down cities in quarantine.
Mm-hmm.
But in America, I tried not to giggle when in California, they said they were going to issue a state of emergency for the coronavirus.
Mm-hmm.
And then I had two different groups of friends who drove to Disneyland this weekend.
Right.
And when they got back, I said, was Disneyland empty? They go, no, it was crowded. I'm like, so that's a very different response of Italy and China closing down a city, but America leaves open Mickey Mouse. What do you make of that?
Yeah, I think it's the fact that, obviously there's a lot of, media attention being devoted to coronavirus. There's probably a lot of misinformation out there as well. I'm on social media and I see, posts that aren't always based on at least what I know to be the best available evidence. And I think part of the problem also is that just the evidence is evolving, on an hourly basis. And so what was untrue yesterday could be true now. What was untrue an hour ago could be true now. So I think there's a lot of just confusion out there. And not to say that we need to be in a state of hysteria, but I think that based on what we do know, I think it is safe to say that, again, the precautions we can take may not just be protecting us, but may be protecting our vulnerable citizens that live next door to us, that are family members. And so, again, I think in a state of such uncertainty, I don't think it's unreasonable to take, the most stringent precautions to make sure we're not contributing to the disease.
One of the silliest terms that I think of is the United States of America. It is such. How do you compare Miami to Wichita, Kansas? How do you compare Phoenix to San Fran? I asked you to be on this show because you put up an innovative training program in Alaska. And I've been to Alaska, and if you cut Alaska in half, each half would be bigger than Texas. I mean, Alaska is a whole other world. In fact, when I went there halibut fishing one time, I wasn't aware of my geography and my history lesson very well because it was sold to the United States from Russia, and I went in. I drove through a town, and it was nobody there spoke English. I was with my dad and my brother, and it was a small town. It was 100% Russian. And then when I got back, and I told the dentist, they go, you can't go to that town. It's a Russian village. Nobody there speaks English. And I mean, so it's kind of children out in rural Alaska have a very different oral health challenges than the ones in downtown Seattle, Washington, don't they?
In many ways, there are differences. Alaska is unique in many ways. It's mostly rural. It's, as you mentioned, a really large piece of land that's pretty sparsely populated, minus the few population centers. So I think in many ways, Alaska is unique. However, if you look at some of the rural communities, if you look at some of the access problems that children as well as adults encounter in these rural communities, they really aren't so different. When you compare some of the access problems we have here in Seattle, or some of the access problems that exist in other communities in the lower 48. So while there are differences, I would actually say that there probably are more similarities in regards to some of the Alaska Native communities I've worked in, compared to a lot of communities we see here down in the lower 48.
And what was the what do you think was any controversial parts of that program?
So the dental therapy program, there continues to be a lot of controversy about dental therapists. So the program was started in the early 2000s, and originally the program was actually supposed to be housed here at the University of Washington, but for a variety of reasons that wasn't possible, and that's the reason why the first group of dental therapy trainees actually went to New Zealand to get their training, and then they came back and started providing care in Alaska in 2005, 2006. So I actually had no role in actually setting up the program. I was actually a dental student when the program was being proposed. I was a dental student here at the University of Washington, so I had no role in setting up the program. However, as a dentist, I've seen the program operate on the ground. And I've also worked with a team of researchers to do the first large-scale evaluation of dental therapists in Alaska. And while the controversies continue, again, I think that there is growing evidence that therapists are making a difference.
Well, you were published in the Journal of Public Health Dentistry. You are quite an accomplished man. I mean, Why is dental therapy? It's kind of funny how history has repeated itself. So let me go back in the day. There was a guy named Bob Barker who was going around trying to start dental hygienists in the United States, and he actually went down in a plane crash, like a lot of the early ones back then. And when he would go talk to a dentist, they would say, "Look, I'm so busy pulling teeth and doing immediate dentures, I don't have time for this." That was what the real world was saying. And then there's always the political people, and they were saying that this hygiene thing was a violation of their principles, and keep her out of there, and they don't need no hygienists and blah, 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 all that stuff. And then here it is. You couldn't get a dentist to say, "Well, don't you want to get rid of your hygienist so that you could do all of her cleanings?" They're like, "No, I want her to do, or him to do cleaning so I can do more other procedures towards my spectrum." And here it is, expanded duty function. My dentist friends love it. They go in there and she does the fillings so they can go over there and spend an hour uninterrupted during a root canal. But it seems like if you don't have a hygienist, or you don't have an expanded duty function, or you don't have a dental therapist, it just brings out this emotional outrage that you're violating their profession and their degree.
Yeah, and I think you hit the nail on the head. I think it does really come down to turf. I think there's a lot of concern that dental therapists, that the profession will start to produce so many dental therapists that eventually it might put dentists out of business. So I think that there is concern about turf. I think that there also, is concern that the scope of practice of dental therapists will continue to increase in ways that will, again, eventually make dentists obsolete. And I think the thing that I tell dental students, I teach public health to first year dental students who, they're just getting started out. Many of them, have a lot of anxieties about debt. About how much debt they're going to graduate with, and I think that those in the know will take advantage of that concern that dental students have, that dentists have about dental therapy, and kind of feed into the mass hysteria that dental therapists are here to replace dentists. And what I tell dental students, what I tell folks is really that dental therapy has a very limited scope of practice. I mean, really, when you think about the types of procedures that dental therapists do compared to dentists, it's a really well-defined, finite set of services, and that we will always need dentists. As long as there is dental disease, we will always need dentists. Now, if we're talking about just, eliminating dental disease, this may get rid of the dental profession, altogether, which, again, the public health person in me, as well as the clinician in me, says, that'd be great if we could eliminate all oral diseases and just get rid of the need for any dentists or dental therapists. That would be a good thing. Obviously, we're far, far away from that. And I think that as long as there is a need for dental care, there will always be a need for dentists.
Yeah, the economics is, I always say money is the answer. What's the question? And my buddy the sapien can rationalize anything if he's got an economic incentive. I mean, if you're going to make money thinking this, you'll think that 9 times out of 10, whether you know it or not. I have the problem in Arizona where, we border Mexico. And I've practiced for 32 years across from the Guadalupe Indian Reservation, and there's not one dentist set up to practice there, but they're always finding a dentist from Mexico who goes in there and sets up shop, but he's not licensed. So, so the good old government will always find, they'll always come out and find them and arrest them and put them in a cage, and the dental board all collapse and they all think they're heroes. And I'm always like, so you're saying that zero dentistry is better than an unlicensed American dentist who's licensed in Mexico? And they look at me like, well, absolutely. And I'm like, where did we lose the human in this conversation? I mean, I thought we're working on a human. And when I first heard, because I've been to Alaska, I mean, I drove. I'm one of the craziest dentists I know. Most of my dentist friends can't believe I did this, but me and my dad and my brother, when we flew into Anchorage, we drove to Prudhoe Bay.
Wow.
I mean, it was the coolest thing in the world. And it's kind of like a lot of Arizona dentists have never even been to the Grand Canyon. And if you go to the Grand Canyon, everybody there is from Japan and Germany. But my gosh, money's the answer. What's the question? That if they see it as an economic threat, they're just going to be against it, period.
And I'm all about, obviously having, care that is high quality. That's safe, obviously high quality, safe, dental care is really super important. And again, I think that's another misperception that is out there, that therapists are these unlicensed, unregulated, clinicians out there just providing care willy-nilly, and that's not the case. Dental therapists, go through a very stringent set of criteria for clinical training. There's licensure, and they're also working under the supervision of a dentist, and so dental therapists are working in tandem with dentists to provide the care. And so that's what we've seen in the YK Delta in Alaska, is that, dental therapists are working as a team, with dentists and hygienists and other members of the dental team to provide care. And so again, I think that there are all sorts of really scary scenarios that can be painted when it comes to dental therapy. And at least in my experience, none of those scenarios, there's just no evidence that that's actually happening. Dental therapy is provided in a very regulated, very controlled environment.
So your study's posted on Dental Town. It's posted how Alaska tribes solved their dental health crisis, and posted all this. And the dentist said, one of the comments says, I would like to add my 2 cents. Solving is very loosely defined here. I work for an IHS facility in Alaska. There is sky-high levels of decay among Alaska natives with little signs of slowing or reversing that trend. Out in the village, it's cheaper to buy soda than water, so everyone drinks it. So this guy is looking at all your work and effort and saying, it's not like he's thrown in the towel, that decay is a big runaway problem. And we have that problem in Arizona, too, that the corruption that you can just see is so amazing. Like, you go in, I've witnessed this a dozen times, where I'm standing at Circle K or 7-Eleven or whatever, and the 2 little kids say, well, the Coke's cheaper because they're getting a bottled water, and it's 99 cents, and the 64-ounce Thirst Buster or whatever is 69 cents. And I'm sitting here thinking, my God, this kid just made an economic decision. And I've seen it with cigarettes, too, where when they raise the price of the tax of cigarettes, they're standing there at the counter saying, I don't know, man, do you want to get split a pack of cigarettes? Because we could go to McDonald's and each get a Big Mac. And then they go, let's go to McDonald's. And I realized, oh my God, they just thought about what do they want, a tobacco or a Big Mac? And it came down to dollars and cents. And half a dozen times I've seen kids pick the big old 7-Eleven Slurpee because it's cheaper than bottled water. How did bottled water get to be more expensive than gas?
Yeah, those are good observations and good questions. I think that back to kind of the title of the Dental Town article, with the insinuation that dental therapists, have solved the oral health access or disease problems in Alaska Native communities. I think that's that's probably a little sensationalized. What we did with our data, we looked at 10 years of data from Alaska Medicaid, as well as electronic health record data. And what we found was that over that 10-year period, those communities that were served more intensively by dental therapists, meaning they had a dental therapist in their village or community providing care, that those individuals living in those communities, they got more preventive care, and that there were fewer extractions. So, taken together, what that tells me is that adults and children in YK Delta communities that are served by dental therapists, they're getting more preventive care, and they're losing fewer of their natural teeth. Now, what that means for disease rates, in fact, that's one of the limitations we have in our study, is that we don't know what's happening with disease rates in Alaska Native communities. However, when people are keeping more of their teeth, and actually we found this with younger children as well as adults, if people are keeping more of their teeth, I think one of the things that you can draw from that, finding is that there's probably lower levels of disease. Now, to say that disease that caries or cavities, that therapists are going to play any role in terms of eliminating tooth decay, I think that's really unreasonable. I think that really applies also to dentists as well as the dental care system. I think that's a really unreasonable expectation of a dental care delivery system. And really, I think you mentioned sugary beverages, and I think that when you think about kind of the root causes of disease, really it's behaviors. It's the amount of sugar we consume. It's the inadequate access to fluoride in its various forms. And I think that those behaviors are really going to be, what we need to target moving forward to actually make a dent in the problem. And so the dental care system is there, obviously, to take care of problems before they get large and to provide that preventive care. But if you're not addressing these behaviors, there's only so much a dental care system can do, whether that dental care system is staffed by dentists or dental therapists.
Yeah, that was a very nice sensationalized clickbait title. I Whoever came up with that title, I'm giving them good marketing SEO 101 because yeah, having in the title how they solved. You're never going to solve a dental problem, are you?
Not that way. No.
Yeah.
And I think that we have a lot of work to do. I think in terms of solving some of our oral health problems here in the country and globally, we have a lot of work left to do.
I did not see all the controversy coming from in pediatric dentistry. I thought that was one of the most. In fact, pediatric dentistry, I didn't really understand it, especially. It's just like, okay, we just do small patients. You do the bigger ones. We'll just do the small ones. But man, when silver diamine fluoride came out, I never saw the Red Sea part that fast. I mean, on Dental Town, it's either you just absolutely love the stuff, and it's just SDF is a rock star who's playing at a theater near you, or you're an older guy and just like, oh, that's just crazy. It's just another flash in the pan gimmick of the day or whatever. What do you see in this SDF, and why is it touching so many trigger points in social media? Why in Dental Town are there just two camps and they speak different languages?
Sure. And I think, silver fluoride, I think for those who are rabidly against silver fluoride, my guess is that many of those, people are maybe clinicians that don't have experience with it. And so silver diamine fluoride is something new. And I think that we know a lot of times, dentists, they practice the way that they learn dentistry in dental school. And so you learn, what you did in dental school, and you might take some continuing education courses throughout your career, but by and large, what you learned in dental school is what you're going to take out into practice. And so for those that are, rabidly against silver diamine fluoride, I think it just might be discomfort with something that's new. Now, to say that silver fluoride or silver diamine fluoride is going to be the silver bullet that's going to save, that's going to cure, again, us of the caries problem in dentistry, I think that's probably not true as well. There's a time and a place for silver fluoride. And again, does it mean that silver fluoride is going to put dentists out of business because we don't need to do treatment? Again, that's not true. There is a time and place for dental treatment. There's a time and place for silver fluoride to be used. And so again, I think that as long as people keep that in mind, really, you don't have to be at either end of the spectrum. It's yeah. And that's my take.
My take is I'm in Arizona. And I've been practicing here since 87, 32 years. And, in one city, in a 5-year period, twice a 3-year-old was taken to an OR for a bunch of pulpotomies and chromosome crowns by great doctors. And she didn't live to talk about it. And so many that's just so emotional. I mean, when you lose a child, so there's a lot of people who see these kids being taken in the OR, and they think it could have been delayed with SDF.
Absolutely.
And dental anesthesiology, it's the only specialty I never did. I mean, I've done wisdom teeth, ortho, I've done everything. I've placed thousands of implants, I've done it all. But I would never, ever do IV station because the outcome. I mean, if my root canal goes south, we lose a tooth. I don't like anything to do with the IV station, but I know there's a lot of pediatric dentists who do not like the volume of kids being put under.
And that's been one of the great things about silver fluoride and how I've been able to incorporate silver fluoride into my practice is one of the great benefits is that especially for our really young patients, we're able to either delay or to avoid altogether a general anesthesia episode, which is good for, I think, everyone. So if you can paint the silver fluoride on teeth and delay treatment, that's great. And again, if you do it at the right time, there are cases where we've been able to avoid not just general anesthesia, but doing restorations on children, allowing those primary teeth that are treated with silver fluoride to exfoliate naturally, and then you kind of start all over with with the permanent teeth that are, that are brand new. And so, yeah, and I think that that's really one of the things I think that silver fluoride can do. Whereas in the past, the moment, you'd see cavities that you knew you could not treat in a traditional setting, that you would take that child to the operating room. And I think what's happening now is that just the number of patients that are being taken in for general anesthesia has increased so much that you're going to have these adverse events. And so, that coupled with social media, again, when these bad things do happen, they get out very quickly. And so people know about it. So for a variety of reasons, I think the silver fluoride, at least in my practice, has really been a nice tool that I can use to again, keep my care quality high, but also do what's right for the patient.
And do you see any of this controversy among, with your specialists, you're a board certified pediatric dentist. Are they all on one side of the fence about this, or do you see them even debating this, or is this controversial in your organization?
SDF, I think it's probably less controversial in pediatric dentistry. Most of the pediatric dentists I know, in some way incorporate silver fluoride into their practices. Not to say that they don't have concerns. Parents come in with concerns about the staining, about the aesthetics of silver fluoride, and so not to say that it's controversy free, but I think it's probably as far as specialties go, it's probably more accepted in pediatric dentistry than maybe some of the other specialties. But that said, I do know, pediatric dentists who just don't use it. They're like, what, I need to provide the best quality care. I need to do restorations to completely remove caries, and not subject my patient to the aesthetic concerns of silver fluoride staining. But so I'd say on the whole, I would say that it's pretty well accepted in pediatric dentistry, but there is still controversy.
Jeanette McLean put a couple of online courses on Dentaltown, and one of them is Silver is the New Black, Improving Your Practice with Silver Diamine Fluoride. Another one was Top 5 Misconceptions. They were the most viewed courses of 1990 of last year.
Mm-hmm.
Why? It was the most viewed. I think it's something like 1,461 course views. She is just, and she was even on the New York Times. Do you think it's such a big story? Because the number one goal of any species is to reproduce and have offspring. You're supposed to replace yourself before you go. Is that why it's so important? In fact, the other end, the nursing home, they say 4% of Americans will finish out their life in a nursing home, and geriatric dentistry isn't even a specialty yet. They just did oral health or oral medicine. There's courses on silver diamine fluoride for pediatric dentistry, but you don't see them for geriatric dentistry because you go into a nursing home. They say the average nursing home person gets one class 5 recipient lesion a month, and I know dentists who take silver diamine fluoride into the nursing homes and thinks it's a godsend. So why do you think it was her course was the most viewed course on Dentaltown last year?
Well, I think it shows that, I think silver diamine fluoride, really, it's been a kind of a practice disruptor, in terms of really changing the way that dentistry is practiced. And I think that when I think about the last major practice disruptor, was probably, fluoride varnish. And that was, probably 20 years ago now. So I think that's really been part of, I think, the interest. I think, again, it's also the fact that, we really have not been teaching silver fluoride for very long in dental schools. So I think, again, back to that issue of, there are a lot of practicing dentists out there who may not know about silver fluoride. And so I think courses like Jeanette's course, I think that those, really do provide, an audience with education that they may not have gotten in dental school.
And what is it about Well, first of all, understand why parents refuse topical fluoride. I mean, it's still. Ever since they did water fluoridation. I mean, water fluoridation. I can see I got off on a bad start because, what was it? Joseph Stalin wanted to fluoridate Moscow. So,
Hmm.
the response on the U.S. Senate floor was Senator Joseph McCarthy walked to the Senate floor, showed a picture of a human brain, and showed with a red dot the area that if you drink fluoridated water, it makes you susceptible to communist ideology. And here, it's 70 years later. Is it because it's fluoride? Is that the controversial part? Why do you think parents refuse topical fluoride?
I think there are a lot of different reasons. I think that parents may be concerned about the safety and the side effects of fluoride. And so if you Google fluoride or topical fluoride, there are a lot of sites out there that really misrepresent the way that fluoride
The
works.
majority.
Yeah. There's a lot of bad information out there, and I think that these websites have gotten more sophisticated over time. I think the other thing is that these websites also link out to very professional-looking scientific papers that may also make conclusions that are unwarranted or not based on data. And so I think that there's just a lot of misinformation out there. Now, what I'd like to think is that, that parents, they make the best decisions that they can for their kids. I don't think any parent out there, or very few parents out there, I think are intentionally making decisions that harm their kids. So I think the starting point with all of this is that, parents want what's best for their kids. And we have a new 20-month-old now. And again, I think that, I know that, coming from my own life, that I want what's best for my daughter. But it's complicated. I mean, there's just a lot of information out there. I think parents are oftentimes overloaded with information, so they do searches, they talk to friends who may then spread the misinformation. I think the other thing is that as dentists and as dental health professionals, I don't think we do a particularly good job about talking to parents about fluoride. So I think that dentistry has a role in this as well. We're actually just finishing up the first part of a study trying to figure out why it is that parents refuse fluoride, and we're still finalizing our results, but it's fascinating, and I think that the take-home message here is that it's a really complex problem, I think, that we're facing.
Um, but it doesn't make sense to me when doctors talk about misinformation on the internet because the doctors are the ones that keep everything behind a paywall on PubMed. There was an article in the Los Angeles Times this week, and it says COVID-19 could kill the for-profit science publishing model because all this information is behind all this stuff. But the ADA, it says COVID-19 could kill the for-profit publishing model. The change would effectively nationalize the valuable American intellectual property that we produce and force it to give it away to the rest of the world for free, according to a December 18 letter to President Trump signed by the American Dental Association and 125 other institutions. So the tax, my good buddy, love her to death, Gigi, in California says research projects are funded by NIH, and that is taxpayer money. All they do is print articles or publish them online and get paid millions by universities and advertisements. Keep in mind that their editors doing peer reviews also work for free. If Dentaltown can send magazines out for free, Elsevier can too. So, do you think the coronavirus might be the nail? Because, like I say, if you Google water fluoridation, the 5,600 studies are all behind PubMed and paywall, and you got to register and sign in. But the fluoride people, man, their stuff shows up first, and it's free. What do you? First of all, what do you think of that letter that the ADA signed and sent to them in support of Elsevier?
Yeah, so really, I think that science that's funded by NIH, actually the way that this works now is that if you have a project that's funded by NIH, within 12 months, actually, any kind of publication, regardless of where you're publishing it, it becomes open access at 12 months. And so it does become freely available. Now, I think the argument is that, look, when it comes to scientific knowledge, 12 months is too long. We need to get this information out soon. And so I am all for open access of getting science out as soon as we can get it out. And I think that publishers have made a lot of money on the backs of academics, as well as the government, government-funded research. And I see, I see the horizon on the horizon. I see this changing. I think that people have caught on that publishers are making not just small amounts of money, but large sums of money. And again, I think this issue of scientific openness, I think, is going to put a lot of pressure on publishing companies to do things differently.
And you said you just had a 20-month-old?
Yeah. So
is that your first baby?
It's our first baby, yeah.
Because my first question to you is on Twitter. You're on at Twitter. You are at Donald L. Chi, but I just see you and two gorgeous dogs.
Oh, that picture needs to be updated. Those are my two old dogs that actually have passed away. So yeah, I need to probably update my photo.
Oh my gosh! Because when you said you had a new baby, I didn't know you were talking about a dog or a human. I'm just like,
yeah,
this is a dog guy. The other thing that the flip side about when a little child goes to the OR, and we had two cases in Yuma since I've been here. And, every time I hear the word Yuma, I just cringe because of those cases. But the one thing that makes me cringe on the other side is that no one ever said, it was always the doctor. It was always the bad doctor. And then he did it again. Oh my God, the bad doctor. And he's not a bad doctor at all. But my question is, they never say, well, why did your 3-year-old daughter need 8 root canals? I mean, I don't have any hair because I drank too many Slurpees. You know what I mean? I had no control. I just assume that my grandma married a short, fat, bald Irish guy, and it turned out it was true. So I come from a family that's predominantly short, fat, white, bald Irish guys. But when that 3-year-old girl needs to be taken to the OR for 8 pulpotomies and chrome cell crowns, how much of that was behavior versus genetics? I mean, was she born unlucky with bad genes? How much of that is just behavior?
I would say the overwhelming proportion of it is behavior, and this is why I think I'm so interested in ways to help families and children improve their oral health behaviors. Because the thing is, like you said, I mean, if these kids weren't consuming so much sugar in the first place, they wouldn't end up in a situation where they would need general anesthesia. So yeah, I think when these unfortunate events happen again, and I have additional context now because I have my own child, and I now understand what it's like to be a parent. I think it really is easy to blame dentists or to blame the dental care system, and maybe some of these instances things weren't done according to protocol. Maybe things weren't done in the most safe way. However, I think parents do have a role, and I think that how I like to approach the problem is not to play the blame game. I think it's so easy when a child comes in with a lot of cavities and dental work that they need, to be really judgmental and to start being mean to the parent and saying, look, what are you doing to your child? And I think that, when it comes to providing care for your child, I think that many parents are really struggling. I think a lot of parents have a lot on their plates. Raising kids is really tough. And if you don't have resources, it's even more difficult. And so I look at my own situation where I'm probably among the most resourced, families that are out there in terms of the ability for us to afford high quality daycare, for us to buy healthy foods for our daughter, to enforce toothbrushing with fluoride toothpaste, to make sure that she, hasn't had a drop of juice. And we're resourced. We can do that. Many families aren't. And I can't imagine how much more difficult life would be if I didn't have the resources I had. And so I think as privileged, individuals of society, I think dentists, oftentimes are overly harsh with parents. And I think that that's really unfair. And I think that parents do have a role. However, I like to look more broadly at what are some of the structural, features of society that got us here. So earlier you mentioned, the size of big gulps and just the how cheap it is to buy sugared beverages and food. There are policies in place that systematically, put parents and families in positions where they make the decisions, in the way that they do because of these structural problems. So while I'm interested in behaviors and behavior change, I think it's also really important to keep in mind some of the policy levers that are going to need to be tapped to solve these problems.
So you did another project with dental care use for Medicaid-enrolled children with autism spectrum disorder in the Iowa SMILE project. Is that becoming a bigger part of pediatric dentistry, autism? And the million-dollar question, is there a rise in autism, or is it just because now we're just woke to it? I mean, when I was a little kid, that one kid was different. Now it's got a name. What is autism doing to pediatric dentistry?
Yeah, I can't speak for the prevalence rate, prevalence rates of autism. I think there are a lot of intricacies, when it comes to estimating prevalence rates. I think autism and special needs has really been one of the defining kind of areas of pediatric dentistry. And this isn't a recent thing. So I think pediatric dentists have historically been the go-to specialty when it comes to providing care for special needs patients. And you see this now if you go to, most pediatric dentistry offices. Most offices will actually have quite a few adults with special needs that continue to be part of the practice. Many times because pediatric dentists don't have a place to refer adults with special needs. I think the other thing is, that we get attached. We get attached to patients over the years, and so we hang on to our patients with special healthcare needs. So I think the study that you're referring to talks about some of the barriers to care that children with autism encounter. Certainly I think, there are, special skills that are needed in terms of treating individuals with autism in a dental setting. And we're obviously very interested in ways of improving the dental care experience for patients with autism.
So do you, I know this is hard to me to ask you, but just for simple math, if I sent you 100 patients, how many would you take to the OR and put under? How many would have nitrous, and how many would you be able to do just by the environment?
Yeah, I'd say most of our patients we would treat in our clinic with either with or without nitrous. The clinic that I work in, it's a community clinic affiliated with Children's Hospital. We don't do any conscious sedation. So the care that we provide is either with or without nitrous in our clinic, or we'll refer a handful of patients to Children's Hospital to be treated under general anesthesia. So, out of 100, I would say maybe, 2 or 3, we would send maybe to the hospital. And the rest of the children, we would treat in clinic. And I would say, contrary to misconceptions out there about, about behavior management of children, most children, and by most children, I say, 95, 96% of children are actually pretty cooperative when it comes to dental treatment, even for really difficult procedures like extractions or pulpotomies or crowns. Most children are actually really, really good patients. And those patients that have difficulty cooperating. Again, it's a very small proportion.
Oh my God! It's still, I don't know how you do it. My hats off to you. I mean, I had a pedo patient last week, and he was starting to cry, and then we got it done.
Mm-hmm.
But that 20 minutes exhausted me. It was my whole day. I mean, everything else I did, and when I was done with him, I just wanted to go. I just want to go home. I told my office manager, I said, Don, can I call in sick and just go home? If you told me I had to switch to pediatric dentistry or leave the country, I would just start wondering which country I was going to go to. Speaking of other countries, my daughter-in-law is in South Korea right now, and
Oh, wow.
and I've been up there. Love South Korea, Mega Gen. I mean, it's a great deal. But you have an opportunity to be a double doctor, a dentist, a pediatric dentist, a PhD, and get to see a very differently defined country and culture versus the United States. What have you learned from really knowing Seattle and Korea? What variables stand out the most that affect disease, missing and filled teeth rates, their overall oral health that you can spot?
I actually think it's pretty similar when it comes to the causes of disease. Cavities are actually pretty widespread in Korean children because of diet. Diet is, a lot of kids are drinking sugary beverages. They're eating snacks, and snack culture in Korea is actually it's fascinating. There are tons of snacks. Actually, I was at Costco the other day, and it was amazing how many Korean snacks that actually I grew up with, are being sold in Costco now. And so, I think snack culture is huge. I think the other thing in Korea is, it wasn't very long ago that the Korean War happened, and all of the fallout from the Korean War in regards to malnutrition and food shortages and hunger. And so when I think about my own upbringing with my parents, it was really important for my parents to make sure that we were fed, and that we were fed constantly. So there was always something, there's always something to eat lying around. And I think that snacking culture, and just the massive amounts of sugar consumption really is what's causing, the cavity or caries epidemic, both here in the U.S. as well as in Korea, as well as most places in the world.
So were you born and raised in Seattle or South Korea?
I was born in the U.S. I was born here in Washington.
It's kind of interesting because I've lectured in 50 countries, and I think Korea is related because whenever you're in China, if you're the Chinese kind of think of themselves more like I was born and raised in Kansas, more rural, small area. But if anybody had a fancy shirt on or was looking hot or bought a new car, they'd always say, "Oh, you're looking so Korean." So it was their version of Elvis Presley. But I also noticed from a business point of view, but the owners, they'd say South Korea, they got Samsung, Hyundai, they got so many LG, and they go, China still, I don't feel like they've reached their self-esteem because they make so many of the parts that go into your LG, your Samsung, Hyundai. But like if you walk into, can you name one brand of something made in China that's a brand in Costco? I mean, Costco's in Seattle.
Mm-hmm.
There's no American brands that are from China, really, are there?
Yeah, I don't know.
Yeah, there's not.
That's a good question.
And that's why everyone in China, they want to dress Korean, listen to their music. They really do. And that's China's entire strategy has just been make it so cheap they'll have to buy it. And Japan and South Korea have all these brands, and they have everyone's attention in the entire East. And in fact, when I was lecturing in Malaysia, Cambodia, Indonesia, I noticed that the dentists there all knew what the South Korean dentists were doing, the German dentist, and the American dentist. I mean, it was just like all the debate. Well, the Germans are doing this, the South Koreans, and yeah, they're really, really following them. So pediatric dentistry has some more controversies I want to, the role of sleep and airway and the tongues roll. Again, I come out of dental school. I never heard of sleep apnea. I never heard of obstructive sleep apnea. Never heard of any of this. And now you can't go anywhere without talking about sleep apnea. And also, when we were little, a baby was born, your mom just nursed it. Now a teacher comes in to show you how to do this thing that they've been doing for a million years. And at the end of the lesson, a lot of moms think their baby is tongue-tied, and the nursing teacher thinks it's tongue-tied. And so I've gotten more questions in the last 3 years than the first 30 years about is my babies need tongue-tied. So what I did is I just threw like 20 questions at you, and I hope that one of them stuck to the wall. Is there an increase in tongue-tied? Is breastfeeding an issue? As a pediatric dentist, what are your thoughts of the tongue in pediatric dentistry?
Yeah, and just in full disclosure, this is an area of pediatric dentistry I don't follow too closely in terms of the literature. So this is kind of going back to again what I learned during residency and what I do in clinic. I don't think there's any reason to believe that the prevalence of tongue tie has somehow increased recently. I don't think that that's very realistic. Now, it may have been underdiagnosed, and so that's always a possibility. I do know instances, there are instances where a mother may have trouble breastfeeding, a patient or infant may have trouble latching, in which case, snipping the tissue under the tongue can actually help with latching. That being said, I think that there is a lot of hype out there that's not always evidence-based. And I think that, unfortunately, I think that there are a lot of clinicians out there who are taking advantage of some of the anxieties that parents may be coming in with. I certainly remember this when our daughter was born. About a lactation consultant coming in and talking to us about ankylosing, and there was no reason to believe that there was any kind of tongue tie problem with Arliss, and it was just interesting again from a parent perspective to hear that. So again, clinically, yeah, we do see tongue tie, and there are cases where a tongue tie, needs to be released and can be done very simply. And I think that's an important service to provide. That being said, I think that there's just a lot of stuff out there that is not evidence-based. And I think that in the long term, the things that we're doing out there that are not evidence-based, there's going to be a time where this is not going to be possible. And I think that in an era of accountability, in an era of evidence-based dentistry and value-based care, I think there's going to be more scrutiny over the types of procedures that we do in dentistry, just like there is intense scrutiny in medicine. And I think that this is going to affect medicine and dentistry in very similar ways.
So in pediatric dentistry, what was the other thing I was going to go with that? Well, if you saw 100 patients, back to the 100, you said 3 would probably need to be put down or OR. What is the majority? What is a day like you? If you were McDonald's, what's your Big Mac, fry, and Coke? Are you doing pulpotomies and chrome steel crowns every day? Is it mostly amalgams or composites or cleanings? What are you doing in real world?
Yeah, so I'd say the most of my time is spent doing recalls. And again, I think that would be the case of most dentists and most pediatric dentists out there, is that the majority of my patients are on recalls. After that, we're probably doing a lot of, composite fillings. So I'd say recalls, cleanings, exams, and composite restorations.
Okay, so let's go to composites. Back to South Korea, Asia, Australia, New Zealand. They use a lot more glass ionomer than the Americans. And GC will tell you that it's a. Do you use glass ionomer, or are you more North American direct resin?
No, so I will use a resin-modified glass ionomer. So for all primary teeth, we'll use resin-modified glass ionomer, and then for permanent teeth, we'll use generally we'll use composite.
So explain that. Why does a primary tooth, and what do you guys call them? Primary teeth?
Baby teeth, primary teeth. Yeah.
Yeah, it's funny when you go around the world. Milk teeth still seems to be more
hmm
common when you go around the world. So explain why a primary tooth would get a resin modified glass ionomer and a permanent tooth would not.
Yeah. So theoretically, I think in terms of wear characteristics, composite is much closer to tooth, and so if you're, for instance, restoring an occlusal surface, an occlusal composite against a tooth, you're going to have more natural kind of wear over time. Whereas with the resin modified glass ionomer, you're going to have more wear because it's not as strong of a material. Now, one of the benefits, or one of the theoretical benefits of resin modified glass ionomer is that there is a fluoride release, and so resin modified glass ionomer theoretically is able to absorb fluoride and then excrete fluoride as well. So you have some added protection when it comes to primary teeth.
And is that GC that you're using? Is that GC resin?
We're using Diract. So yeah, we use
Diract. By who? Direct by who?
I don't know.
And then what are you doing for the permanent teeth then?
For permanent teeth, we will use TPH.
TPH.
Mm-hmm.
And so resin modified glass ionomer Diract. Why do you think glass ionomer is so much bigger in Australia and New Zealand and Japan and South Korea than the U.S.?
I don't know. That's a really good question. I didn't actually know that was the case. So yeah, I don't know.
Yeah. Space maintainer. That's another thing. People are always you got to keep that tooth in there to keep the space. And then as it starts getting closer to age 12, you're like, they're going to get that permanent teeth in a year. Dentists are looking at that bite wing, and you see the head of the permanent tooth already between the roots. What are your thoughts on space maintainers, and any tips you can give us there?
Space maintainers, we do them when they're needed. I think that the first and foremost thing that I think about when it comes to maintaining space is that, if you put a space maintainer in, that increases potentially the caries risk of that patient because of hygiene related factors. So while obviously it's important to make sure that you're not contributing to orthodontic problems, I think first and foremost, what's important to me is that I put a space maintainer in a mouth only when I know that the hygiene is actually going to be, impeccable, because I don't want decay around that space maintainer. I don't want caries to be a problem before that space maintainer is removed. So I think that hygiene considerations are probably the single most important thing I think about when it comes to whether I place one or not.
Do you miss amalgam? Amalgam, it just lasts forever. We're talking about occlusal. My gosh, on that kid I had last week, I drilled out that little hole, and he was starting to lose them, so we switched right to amalgam, triturated, boom, boom, boom. It saved the whole day. And if I couldn't have flipped to amalgam instantly last week, I would have had to refer a little 7-year-old. And everything I read on amalgam, my God, it's metal. It's half mercury. You're never going to find that in a multivitamin. The other half, silver, zinc, copper. The whole thing is antibacterial. Why are we not using occlusal amalgams in pediatric dentistry?
Yeah, I think that's a really good question, and I miss amalgam too. I haven't used amalgam since I graduated from dental school in 2006. I think this is an instance where parent concerns have kind of restricted the kind of materials that we use. And so I know that a lot of parents, when amalgam was being used, commonly parents would come in with concerns about amalgam. I think there are probably the legitimate concerns about environmental impact. And so we know that, amalgam waste, can be a problem. But yeah, I think as far as longevity, as far as, when you're thinking about patients at high risk for caries, you have to wonder, are the composites that we're placing in our patients really the best materials for our high risk patients? And I would say, again, that is not the case. I think a lot of the patients that we place composites in, probably would be better served if they could get amalgam fillings.
Oh my gosh. I mean,
Yeah.
when someone tells me their composites last longer than amalgam, it's like you can't even continue the discussion. I mean, this person is so out of their mind from research. I mean, the research shows, I mean, paper after paper, 38-year average life expectancy compared to their 6-year plastic inert stuff. But the only thing that's wrong with amalgam, in my view, and it's a serious problem. It's dental amalgam is 6% of the atmospheric mercury toxic in the biosphere. But that's because you're cremating humans that have amalgams in their teeth.
Sure.
And I don't believe in cremation either. I don't think you have the right to eat all these plants and animals. And then when you die, you should be thrown back in the biosphere and be fed to the eukaryotes and prokaryotes and fungi and let everybody eat you. Instead, you're like, oh, hell no, I'm going to incinerate myself and just send the energy out into the cosmos. Well, when you're doing that, you're also putting a lot of mercury vapor into the air, and that's not cool. Do you have a problem going to digital dentistry with trying to find size zero sensors back? Do you wish you were on amalgam and film? Is it tough switching to composites and size zero digital sensors to put into a 3-year-old's mouth?
Not really. No, I think in terms of I do miss amalgam. I think when it comes to digital kind of radiography. I think that there are times where it actually is really nice to have the little film kind of in your hands, and you can actually do some measurements on the film. Like, when you're doing endo, you can actually do a little bit of measurement with the film in your hand. So I do miss that. But at the same time, I feel like we're moving toward more and more digital over time, and so what do you do in that situation? I think you could just kind of move along with the times. But yeah, I do when I'm in a clinic that's all digital, there are times where I wish I could have the films in my hands.
I can't believe we went over an hour. Is there anything that I should have asked you that I did not ask you?
Let's see. I think one of the things that I think I've been more interested in recently is kind of this issue of science literacy and evidence-based advocacy. And I think it actually ties in with a lot of things we've talked about. And this is something that I talk to dental students about when I'm teaching dental students about public health. And I think that there's such an importance. I think that it's so important for dentists to be science literate. And what that means is the ability to read a scientific article and to point out the limitations, as well as how that article might actually affect the way that they practice or policies that they may end up advocating for. And so I think science literacy is so important. And I think that, dental schools could probably be doing a better job. And by that, I mean myself. I mean, those in dental schools teaching dental students could be doing a better job. And the reason why I think that this is so important, especially now with so much mis and disinformation, is that there's a lot of advocacy out there that isn't entirely evidence-based. And I think what that does for the profession when people are advocating for things that are not evidence-based is that I think it cheapens the profession. I think
can you be specific with names, or what are you talking about?
Well, and so when it comes to, for instance, dental therapists, I think that that they're the kind of the people who are against dental therapists, a lot of times they will advocate against dental therapy without referring to the scientific literature. And so I think that it's really important to keep in mind, I mean, you can still be against dental therapists out there, and there probably are legitimate reasons maybe to be for or against anything. But I think it's really important when, for instance, talking to policymakers, that we advocate, and that we advocate based on the evidence. And I think that I've seen multiple instances of, for instance, here in Washington, we had there was a dental therapy legislation that was under consideration. And there was testimony that I would hear, listen to, that wasn't evidence-based, and in fact, a lot of it was kind of using scare tactics of saying, "Oh, this isn't safe. Oh, this isn't, dental therapists aren't safe. Dental therapists, this is a slippery slope in terms of what this will mean for dentistry. Patients end up getting substandard care." And those statements are fine, but they're not really backed by anything. And I think that is, it's really irresponsible. So I think that, especially with dental students, dental students oftentimes, like they do here at the University of Washington, they have an opportunity to participate in what we used to call Lobby Day. I guess it's not called Lobby Day anymore, but they go to Olympia to talk to state lawmakers about legislation they should support and not support. And again, I think that given that dental students, residents, dentists are out there advocating to policymakers, I think it's just important to make sure that you do some reading and that you kind of know what you're advocating for. And I think that in the end, evidence-based advocacy is the best kind of advocacy that we should do, because the public is putting a tremendous amount of trust in dentists when it comes to our profession.
So speaking of trigger words and trust, Pew is a trigger word in trust. I mean, it seems like you either love them or it's a conspiracy. What are your thoughts on Pew Trust? And do you agree that just saying that it came from Pew? There's dentists on Dental Town that they're done, and it's like, where does this come from? So what has your experience been with Pew?
Yeah, and in full disclosure, all of my dental therapy studies were funded in part by Pew. And so, again, I think to categorically say that Pew, funds work that is in some way biased. Again, I can't speak for the other studies, but as in regards to the studies that we've published with funding from Pew, again, I would ask people to be specific about what exactly is it about our studies that concerns them. Yeah.
Well, they're very smart. You know what the name of their magazine is? Trust Magazine.
Mm-hmm.
I mean that because I've always said my whole life that the number one thing I've seen erode from my 57 years on this rock is the erosion of trust. I mean, it's just been going down every year. I mean, when I was a little kid, I mean, I grew up, in Kansas, the Catholic Church, the government, America, everything. And the U.S. Congress has had about an 11% approval rating since 1980. And so it's kind of interesting now how people just trust is just it's a big issue. And that's why I really hope this paywall with the access to the information. I mean, again, you search water fluoridation. Any bozo can have a website. And by the way, so I infiltrated them because I always wondered what's that all about. So I joined an anti-fluoridationist group and got really deep into them. And I figured it out. And well, it took a while, but I figured it out. Money's the answer. What's the question? When they talk about this, whether you're for it, against it, whatever, when you're done, you're going to buy a reverse osmosis water unit. And they have the best one, and the guy there can install it, and they can finance it, and it basically is a lead generator for either an RO system, a water softener, this or that, and so people have right to be skeptical. Any other issues?
Well, and just to actually follow up on your last point again, and this is why science literacy I think is important, not just for dentists. So buyer beware. I think that regardless of who funds a study, who's published it, I think buyer beware. I think we need to all be super critical when it comes to reading the literature, and part of that is science literacy. And I think that dentists certainly need to have the tools available to them to be able to critique and understand the limitations of studies. But I think that this also, generalizes to the public. I think that we've done, generally a really bad job about making sure that our population, has high science literacy. and hopefully there are some more resources being being devoted to this issue, because I think it really is it's a potential threat to democracy when it comes to a population that isn't able to read something and say this is valid, or this is not valid.
So since you're a pediatric dentist and you're from the University of Washington School of Dentistry, wasn't the last dean a pediatric dentist, Joel Berg? So is he your role model that your next, after you got 2 doctorates, is the next to become the next dean of the University of Washington School of Dentistry? Isn't that a cultural thing in pediatric dentistry at Washington?
And Joel was one of my first pediatric dentistry teachers here at UW when I became a third-year dental student. Joel taught me pediatric dentistry, and so he's an old teacher and a friend.
Was he a dean? Was he the dean too when he was teaching you?
Let's see. He was department chair then, so he was chair of pediatric dentistry. And I love what I do now. I spend time teaching dental students. I see patients a day a week, and then I spend the rest of my time doing science. And I really love what I do. And so yeah. So do I want to be a dean? Probably not. I love what I do now, and I see myself continuing on this track.
I told him, Joel, I felt sorry for him being the dean. I mean, it's hard to get, dentists are so educated, and so it's hard to get them to agree on anything. If you want 100 people to believe everything you say, make sure they're under 18. But once they all have a doctor dental law degree, it's like herding cats. And I've been in ADA meetings, I've been in dental meetings, and every dentist knows everything. And you would just be lucky to get them to all agree that today is Monday. And on that note, thank you so much for all that you do for dentistry. And on behalf of all the dentists in America who would quit if they had to be a pediatric dentist, thank you for doing it for us, because we won't do it.
Thanks, Howard.
Thank you. Have a great day.
Thanks, you too.